Good morning. My name is Anita Day. My pronouns are she, her, and I'm chair of Eastern North Herts Teaching NHS Trust. Today is Wednesday, the 11th of March, and this is a meeting of our Trust Board in public. And I'm delighted to welcome members of the board, a very special guest this morning who I'll introduce shortly, and anyone who might be joining us online. First of all, just a quick apology. We are aware that there seems to be a problem with YouTube this morning, so it's possible that you can't actually access this in real time live. What we are doing, however, is recording it, and we will put the recording up. But apologies if to anyone who won't be hearing this apology, but at some point you'll realise that we did know about it anyway. We have, as always, a really good and interesting agenda, so I'm going to get straight on. First of all, declarations of interest. Does anyone have any specific declarations relating to this morning's agenda? I don't see any hands. Thank you very much. Obviously, our normal declarations are on the website as normal. In terms of apologies for absence, I've received apologies from Kevin O'Hart, our Chief Kaizen Officer, from Stuart Dalton, our Director of Corporate Governance, and Ivana Chalmers from Health Watch Hertfordshire, but I'm not aware of any other absences. Let me then go straight into sort of one of the most interesting parts of the meeting, and I'd like to welcome Boc Pineda and Penny, who's going to be introducing him. Over to you, Penny.
Thank you very much. I'm delighted to welcome Boc to the call. So Boc is with us as an advanced critical care practitioner. And the reason why I thought it was really important that Boc's story is shared with the board and colleagues watching is it's the story of an internationally educated nurse, over 25 years NHS service, progressed from a staff nurse to advanced critical care practitioner, an independent prescriber where he is now. And it's a really kind of inspirational story reflecting resilience, professional growth, leadership development, and the contribution that internationally educated nurses provide to critical care services. And it can demonstrate really how workforce stability, opportunities through education and inclusive leadership can really contribute and help long-term retention and success planning. Additionally, it represents the story of advanced practice within critical care and the impact of international recruitment on sustaining high acuity services. So I think if I were to leave you with anything, this is a story of inspiration. It inspired me and hopefully it inspires you. And Boc, over to you whenever you're ready.
Yes, good morning. First of all, I would like to thank you guys for giving me this opportunity to share my story or my journey for the last 25 years in the NHS. And I hope, as Penny said, this will be an inspirational and inspired other people with my story. So my journey in the NHS began in October of 2000 as a staff nurse at Queen Elizabeth Hospital at King's Lynn. I came from the Philippines where I completed my Bachelor of Science in Nursing in 1994. And like many other international educated nurses, I arrived with clinical knowledge, determination, and deep commitment to patients' care, along with a slight underestimation of the British weather and the British expressions when I first came. When I first arrived, internationally educated nurses were not referred to as OSCE nurses as of today. Back then, we were known as adaptation nurses. We completed a period of supervised practice. Usually it's around 6 months to 12 months before obtaining an NMC registration. At that time, structured OSCE preparation programs were limited. Formal pastoral support systems were still developing, and international peer networks were small. So we learned by doing, we adapted by observing, and most importantly, we supported one another. There were also some cultural adjustments. When a patient told me they needed to do number 1, I generally thought I had missed a clinical assessment scale. When someone told me to use the lift, I was looking for the elevator. And when colleagues said to me, it's raining cats and dogs, I did not really quite understand. I look on the window, literally, really. And when someone offered me a cup of tea, I momentarily thought that they were asking for a raincoat because back in the Philippines, a capote or capote is a raincoat. So yes, there were translation challenges as well. There were also technology challenges. We started, there were no electronic records, no mobile phones. So if I wanted to call my family in the Philippines, I need to queue on the phone box that time. Hospital beds were not all electric. We pumped them manually, and documentation was handwritten. Observations were calculated by hand. We didn't have dashboard. We had strong backs and strong handwriting that time. But despite of all that, I discovered something powerful in the NHS: opportunity. Over the years, I worked across intensive care units, building strong clinical foundations. I completed my critical care course in 2009, and I became a nurse team leader in 2010, then a senior charge nurse in 2015. But perhaps the most challenging period of my career, and for many of us, was during COVID pandemic. At that time, I was a ward manager in critical care. COVID brought uncertainty, fear of the unknown, and immense pressure on both patients and staff. As a manager in the unit, my responsibility was not only to maintain safe patient care, but also to support the well-being of the team. One of the biggest challenges was ensuring we had sufficient critical care capacity and skilled staff. To support the service, I helped to train the theater and recovery nurses daily so they could safely assist in caring for critically ill patients. It was a time when leadership, teamwork, and resilience were tested like never before. But it was also the time when I saw the very best of the NHS: collaboration, dedication, and compassion. In September of 2021, my career shifted. I began my training to become an advanced critical care practitioner. And in 2023, I became a nurse independent supplement prescriber. And in 2024, I completed my master's degree in advanced critical care practitioner at Anglia Ruskin University. And in November of 2025, I also completed a minor illness course. Today, my ACCP role, I perform advanced clinical procedures that were traditionally only carried out by doctors. This includes intubation of critically ill patients and inserting invasive devices such as central lines, VASCAT, arterial lines, and many more. Responsibilities that require a high level of training, trust, and clinical competence. But this journey will not be possible without the support of many people. I have been fortunate to have incredible mentors within the ICU team, particularly my previous mentor, Wendy Collier, who is retired now, who often I refer to her as my work mom. Her guidance, encouragement, and belief in my potential have played a huge part in my development. I'm also grateful to my colleagues and the consultants who continue to teach and challenge me to become the best version of myself. And in my ACCP role, because in critical care, learning never stopped. When I moved to this trust, the East and North Hertfordshire Teaching NHS Trust from King's Lynn, in 2002. At that time, I moved because my girlfriend encouraged me. She's now my wife. And she is also an internationally educated nurse. She began her journey in this hospital in 1999, and today she serves as a matron in Critical Care Group 3, within 27 years of service in the NHS Trust. So when people ask me why I moved to Lister, I think it's because of love, I think. But I stayed for purpose. What makes this story special is not simply that we both work here. It is that we both arrive as international educated nurses, adapting to new healthcare system, a new culture, a new climate, and a new professional language. We both started learning. We both grew through the system, and today between us, we represent a fourth frontline critical care advanced practitioner and divisional nursing leader. That is what international recruitment can become when it is nurtured properly. It is not simply about filling vacancies. It's about building the future. Over the past 25 years, I have seen enormous changes. Paper notes became electronic system, manual beds became fully electric, phone booths replaced by smartphones, international nurses became prescriber, practitioners, matron, and system leaders. Today, when I see structured OSCE pathways, international pastoral support programs, mentorship opportunities, and clear career development routes, I feel proud because the system have evolved. It has become more inclusive, more supportive, more intentional. International nurses are not temporary solutions. We are long-term contributors. We are mentors. We are leaders. We are part of the fabric of the NHS. The NHS gave me the opportunity. In return, I have given commitment. My story is not unique. It represents many international educated nurses who arrive uncertain and grow into the system, stabilizers and leaders. We come for opportunity, we stay for purpose, and when we supported, we grow into leadership. And above all, I believe that this journey have been guided by the faith and by God's grace, helping me through challenges and the opportunity along the way. So with a grateful heart and a clearer sense of purpose, I continue to serve and to grow. And so the journey continues. Thank you.
Bok, thank you very much indeed. That was a lovely presentation. And as Penny said, really, really inspirational. I'm going to open it up to questions or comments from people, but I know everyone will have been as impressed as I was by that. Any questions or comments for Bok? Adam.
Yes, thank you again, Bok. Fantastic to hear. And I guess a couple of things that jump out to me for the board to reflect on maybe is one is that sense of the interconnectedness of our staff. So we have lots of examples where relatives, married couples, siblings are working together, and it just reinforces the importance, even more importance of being a good employer, because it matters more than just on an individual level, but there are families that are so intertwined and connected with the trust. And the second point is you use the word purpose 2 or 3 times there, and we've got an item on the agenda later on talking about our strategy and how we devolve that. But I think a real salient reminder of the importance of connecting 7,000 people with the purpose of what we do. And in your kind of role, that becomes easier because on a day-to-day basis, you're impacting people's lives very directly, including saving people's lives. It's that for many of our staff, that immediate connection isn't there, but it's so important that we connect them with purpose because, it, as you highlighted, it makes such a difference, and it's why people stay and it's why people want to be part of Eastern North. So thank you for those kind of reminders, even beyond the fantastic story of progress and development.
Thank you, Adam. Lucy.
Thanks so much, Bok. Just wonder what advice you would give yourself, kind of 20, the version of yourself who might be arriving now at the same age you were when you first travelled here.
Oh yeah, I think as I've said, this 25 years is not all easy. There were some challenges along the way, but I think with just really focusing on what you want to become at the end of the day, that will really help you push through with your career. And obviously, you need to set a time on yourself as well, on how you develop, use the people around you and support, and make sure that you love what you're doing. And that's the main thing, that you love to go to work daily. And that was really made a lot different, make easier for me to where I am now. I remember when I applied for my managerial as a band 7 that time, there was a question in there, what makes you go to work? I told I told the panel that for me, work is really the love that's that's the love of my career. I always wake up every morning. I don't really start with stress about the staffing, the bed situation that time. I just love to work. I just like to contribute if whatever I can to the team. And for the generations nowadays, obviously these are new generations, young generations, and I see because I also had this opportunity to do recruitment that time. So I see them very eager to start with, but after that, you'll see them that ICU or critical care is not for them. I think it's too much for them. I think the young generations nowadays are more on like to work on a different kind of environment, if you see what I mean. But for myself, I really want to learn. I like the adjustment was really huge that time. And I'm an ITU trained in the Philippines, but all the equipments are different and they're more advanced when I came over. So I did give myself, like, in 6 months' time, I should be doing this. I should know how to operate this safely, and I should be able to be confident of how to work in intensive care. So I think that's what you really need to, for the new nurses or the new generations at the moment, you really need to have the drive and the focus on when you want to become at the end of the day. Because if you're not happy, there's no point.
Yeah, very wise words there, Boc. I think most of us would really support that. Richard.
Yes, well, thanks, Bob. That was indeed a very inspirational story, and you're a great example for many. I'm really interested, as an advanced critical care practitioner, as a prescriber, you do more medical work as well. You make medical decisions, you perform some medical acts, and I'm really interested in, and I see that there's a really important thing going forward in our practice. I'm interested, how does it work with the other nurses? How are they looking at you? And how does it work with doctors? How are they looking at you?
So the ACCP, I believe it's all started in 2017, if I'm not mistaken, and it all started in up north. There was some, to start with, there was like confusion in what the role is, and they really don't know where to fit the ACCPs. But now I think within the last few years, or since I've started in 2021, I think we are more well known now to the trust and to I think all over the UK now. I think we're building our team, because we also have like regular meetings as well, which we have one leader who do the meetings. And ACCP, I think, to start with, is just to fill the gap, I think, within the junior nurses, because we are in between the doctors and the nurses. I think that's what the role is, and to be able to perform and advance things for our patients. And that's why the training includes all the like the intubation and all the other stuff that the doctors do. And we are now on the medical field. I'm now off with most of my nursing bedside care, because it's more on like, it's still a patient's focus, but my thinking now is totally different, because I need to obviously know the diagnosis of the patient, and then the treatment. I'll be the one who's laying what the treatment is and presenting it during the ward rounds. So we work now closely with the doctors, and we are under clinical lead as well with one of the consultants. ACCP in intensive care, there's 3 of us at the moment. Hopefully, it will still build some more if we have like the budget that we need. And so we also work with we now work with the junior doctors. And the good thing about us is we don't rotate. Not like the junior doctors, wherein every 6 months or every year they need to rotate. Us, we stayed. So the new junior doctors are relying on to us as well on how the system work, how East and North Hearts works in critical care, because all the ICU that they probably were designated are totally different practice as well. So, but I still support the nursing. We still support the nurses. Like that last December, I think the plan was, because we were really too busy with the patient's acuity and the bed situations, we were asked if we're not that busy and good staffing with our role, then we will support the nurses. We'll be back at the bedside to support the team. And that's the advantage of it. They can use both of our skills. They can use our nursing skills at the same time if we need to, if they need our ACCP roles, which is our main role, then we are there for them.
That's great. Thank you. Teresa.
I think, Bok, everybody said everything I wanted to say, but, you really are the bridge across, clinical expert practice and in critical care, and making a big difference to nurses and doctors who may not be familiar with intensive care workings, and that administration of vital insertion of whether it's in endotracheal tubes or access to big vascular lines. So you are the glue that holds that all together. So thank you for doing that. And you're an incredible advocate for the service, for the specialty, of which I am a very old veteran. And to see your role working at this level, the glue across our doctors and residents, our anaesthetic colleagues, our nursing colleagues, and all who touch intensive care is really phenomenal. And also the work that you play in Martha's role, we've touched on at the board previously, the importance of complying with these key national standards. And of course, you're partly at the forefront of that as well. So major thanks on behalf of all your nursing colleagues. Keep going.
Thank you, Teresa. Finally, Nina.
I completely agree with all of the comments that have already gone before me. Bok, I thought your story was really inspirational, and thank you for sharing it. And so eloquently put together as well. So thank you. And my question is really, what advice do you have for us as a board, so that the next generation of people that are coming to work at our organisation, that we can support them in the same way that we've supported you?
I think, as I mentioned a while ago, that the system now is well structured on the international educated nurses, and even for the new nurses, the new graduates. I think a good program for them as their baseline, and continuous support for them will really good help with our staff retention, and obviously with the workload as well. I know that the staffing obviously it won't gonna be solved in like we've been struggling that for many years now, and it's not only our trust. Wherever you go, it's the same issue, it's the same problem. So I think it's just how to support the nursing team, the junior doctors as well, in order for them to feel that we are one, that we are united on our goal, on what we want to achieve. And I think that's the main thing for us. With me, the advantage of obviously working for the last 25 years now, all our consultants in ITU were all my regis before. So they became registrar before they become consultants. So I knew them from they were just junior doctors as well. So it's easy for me to work with them and to plan ahead on, or to be involved with the planning of intensive care. So which is really an advantage for us. And at the moment, I'm working with the IV Access team with Sister Dagmar in order to support her as well with their team, because they're really, well, she told me that obviously there's like few of them, and I'm trying to train to do this for them as well, and and be able to perform whatever for our patients if they need this invasive lines.
Thank you.
Thank you, Bok. I don't see any other questions. So just to finish, as everyone has said, we thank you so much for making the time to speak to us today. I think your passion and your commitment to us is just shines through. And I think what your story shows is that if you do have that commitment, that passion, that thoughtfulness about where you want your career to go, actually you can absolutely accelerate that progress. It sounds to me like that we are very lucky to have you and your wife working with us, so thank you very much for joining us today.
Thank you. Thank you as well.
Thank you. Bye-bye.
Bye-bye.
Well done.
Have a good day. Bye.
Well done.
Great. Lovely. So let's move on to the minutes of the previous meeting, which are in your pack. Could I get confirmation that we are happy with them? Are there any changes or clarifications that are required? No, I don't see any concern, any hands raised. So are we happy to accept those as a true record of that meeting, please? Thank you very much. Then moving on to the action log. Debbie, could you take us through this, please?
Absolutely, Chair. So the action log is marked as green, as all the actions are completed are on the agenda. And just to also point out that the second action there, the integrated performance report, the executives actually looked at this and it was felt that the quadrant is a mixture of measures and therefore it's not viable for it to have an overall insurance, which was a request of the NEDs at the last meeting.
Thank you for that, Debbie. As I said, we'll pick that one up separately to see whether everyone is comfortable with that. But I think thank you very much for the update. Any questions or comments on the action log? Nope, great, thank you. Public questions, I think I asked you earlier, Debbie, and we don't have any this month, do we?
We don't. As at this morning, because I heard from Stuart, there were none.
Brilliant, and hopefully Stuart will be back with us by next time. Thank you very much, Debbie. Moving on then to my report, a verbal one as usual. Just a couple of things I just wanted to highlight to us all. As some of you know, a couple of weeks ago, Adam and I attended a regional meeting of the chairs and chief executives, which was attended by Sir Jim Mackey. I think in terms of messaging, it was very much consistent with what we've heard before, but really just reinforced some of those things and some of the challenges that the region will face. But I think for all of us, one of the great advantages or the great positives from those meetings is it really gives us a chance to connect with colleagues from across the region and find out what's going on in their patches. So that was an interesting meeting. I think also we are all aware that this is the last month of our old ICB, Hertfordshire and West Essex. As of the 1st of April, as you know, that ICB is coming together with Cambridgeshire and Peterborough and Bedfordshire, Luton and Milton Keynes to form a new ICB called Central East. It's a large patch. I think it's supporting 3.5 million people right the way across the east of England. We Adam and I and others have met the leadership of the new ICB, and I think there's lots of cause for optimism going forward. The ICB to that end have already identified what they see as their 5 priority areas of focus, which interestingly and probably thankfully are not a million miles away from the 5 priority areas that we as a place partnership, the HCP, had already identified for our Part that ICB. Then it's not 100% alignment, but it's actually pretty close, and work is underway at the moment to try and kind of align that fully. But actually what it does reveal very clearly is that all of us are conscious of the challenges and recognize that they need to be our focus. We just have there's some slight variation based on our particular patch. Having mentioned the HCP, the PLACE partnership, again, just to mention that as board colleagues know, a couple of weeks ago we had our second board-to-board meeting with the board of Hertfordshire Community Trust, one of the key partners in our HCP, and it was really gratifying to hear of the great work that our trust and theirs are doing together in a number of areas. And finally, as some will be aware, tomorrow marks the publishing of this year's National Staff Survey results. They will come out sometime tomorrow. I can't quite remember when, but they will come out tomorrow. And it's always a really important time because it allows us to see what are the things that we have, the steps we're taking to improve staff engagement and the issues that staff tell us about, the progress we're making, but also identifies the areas where we still have work to do. So we very much look forward to that and using those results to shape our actions going forward. I think that's all I plan to say, unless anyone has any questions for me. So since I don't see any hands, I'm going to hand over to Adam for his report. Thank you.
Thank you very much, Anita. So you have my usual Chief Exec's report here, just picking up on a few broad themes. I'm just going to draw out about 3 issues. Clearly at the moment, as well as getting very close to the end of this year, and striving to deliver the targets that we've agreed for ourselves this year, and progress is good in that regard. We've been busy in the planning for next year. Significant challenges to be faced by all, because we know areas like waiting times are not where the NHS want them to be. We know the continued financial challenges of trying to be more and more productive, and those things go hand in hand, because the more productive we are, the more patients we can treat. So going into next year, we are building a transformation program, which focuses on areas that are beyond the business as usual. We're calling that Better Care, Better Value, and it's with the intention of making strides in all those areas. So that is currently being built. It's being underpinned by our production system, and we'll also look to draw and bring in some expertise where either we don't have the specific skills or the bandwidth to do everything at the same time. So that's currently in development, and we'll have more through the year as we report on that work. Anita's already mentioned a fair bit of work engaging with partners, not least the university, and we hosted the Vice Chancellor, and that was a really positive visit, and now continue close working as they become a medical school later on in this year. And we consider our path potentially to university hospital status, particularly driven by those links going forward. So it was good to welcome him and show him the work we're doing in research, but also the day-to-day activities within the trust. He is an individual with a strong interest in medical research, a strong background personally as an academic, but I think we felt a really strong connection very early. And Justin, obviously, with his links being part of the governance arrangements of the university, really cements that in, as well as Zoe, obviously sitting on our board. So really strong relationship. In terms of digital, we're clearly putting a lot of focus on our One EPR, new electronic patient record system that we'll be bringing in later in the year. But it's also worth mentioning there is an awful lot of other digital enablement. And one area that we're very conscious of is the way our patients and our community can interact in a modern way that we spend most of our lives. And it's great to see that the vast majority now of our outpatient clinics are now able to use the digital system. That means that patients can engage through the NHS app in terms of understanding their information, receiving data, rather than the traditional method of letters in the post. So really great progress beyond our main estates programme. And then I just want to highlight, because it's understate it. We've really received a huge level of capital investment coming our way. It was announced over the last month that on top of our routine capital that we get each year, we've largely doubled it in our allocation into next year. And for some specific projects, and probably most excitingly, is the ability to build a brand new paediatric unit. Anyone who's been around our inpatient facilities will know that despite the excellent care that the team give, the facilities are not fit for modern healthcare. And it was always going to be a struggle to identify the capital within our underlying resource to do that. And so it's great we've been allocated that money. The team are busy working through the plans that will still need to be finally signed off by NHS England to release the funds. But what's really positive is that the work had already started. The teams have been massively involved already in designing what that could look like. And then very soon afterwards, we got more news to say we've also been given funding for 4 new scanners, CT and MR, which we know are a huge part of modern medical practice, and also the ability to really upgrade an urgent treatment centre. We opened our temporary one that has just seen more and more activity going through, and an opportunity to do something built for purpose rather than a repurposing. So some really exciting stuff on that allocation. And I know we've been talking a lot about our investment and significant investment we've made in renal dialysis, but we also know that a big part of that kind of regime is how can we empower more and more people to self-dialyse at home. And so being able to invest with some more capital funding in creating a bigger home dialysis centre that will train more people, support them in doing that at home, again, feels a real positive at a time when we know national finances are constrained. And finally, on top of the various reflections I've said, where it seems to be a common thing now, we're having staff shortlisted for national awards and winning them. I just want to make mention of Mr. Tim Lane, one of our surgeons who has been appointed as the president of the Royal College of Surgeons. It's the first time members have voted for their own leader. So huge congratulations to Tim, who takes on that role later on in the year. But it's worth noting that alongside Tim, Dr. Jeanette Dixon, who is one of our consultants based over at Mount Vernon, is the chair of the council of the Academy of Royal Medical College, where all the presidents meet collectively. So to have 2 of our clinicians in such important influential roles, I think is real reflection on the quality of the clinical staff we are blessed with in this organisation. And for our size, it feels we're really punching above our weight in that regard. So congratulations to Tim, and thanking him actually for stepping forward to take on such an important role. But that's all I wanted to draw out from the report. Thank you, Chair.
Thank you, Adam. Any questions or comments for Adam on his report? No, I don't see any hands. Oh, there you go, just in the nick of time. Karen.
I just wanted to reflect upon how important it is that we have actually got that investment in capital. I've been on the trust board for a number of years, and I am truly delighted to hear that we're going to be able to rebuild Bluebell and to actually build a fit for purpose paediatric unit. So I don't think it can be understated just how good that is. But also to be able to get investment in the urgent treatment centre as well. It's a part of the hospital that I myself have used. I think for it to be built in a different in a fit for purpose way would also be extremely good. Although I have to say that when I have been into the UTC, that I've been treated extremely well. So all in all, I just really wanted to say that I am delighted to see this sheer investment that we are now getting in our capital.
Thank you, Karen, and completely agree. I think this could really be a game changer for us in the next year or two. So absolutely. And I also agree, by the way, I've also been a patient at the UTC and I was treated fabulously, but it would be lovely if they had some, as with the paediatric unit, the care we provide is outstanding, but actually to have the facilities that are modern and built for purpose will just make such a difference. Teresa.
It's just great to get this news about paediatrics, Chair, and I think the seminal work that the paediatric team have undertaken around co-design with their estates colleagues, facilitated by the production system, is going to be absolutely instrumental to that future state. So the timing is absolutely perfect. So great news, and thank you, Adam.
Absolutely, and as you say, really important that co-creation part. If we have no other questions for Adam, thank you very much. We're going to move on to the strategic goals cascade. Now, unfortunately, Kevin O'Hart cannot be with us. Adam, are you able to talk to us about this?
Yeah, very happy to. And as usual, I think Kevin's reports are always very clear and full. So I will just draw out a few reflections from it rather than take people through section by section. So board members will remember we came a few months ago after a development exercise looking at our priorities for this year. That certainly Karen was part of that from the inception. We agreed about 3 years ago our trust mission and then our vision where we wanted to be by 2030 at that time, with our 4 guiding themes, the areas we felt that if we focused on, it maximises our chances to bring that vision to life by that time. We then went through the processes of choosing in-year priorities that we felt would shift the dial, and we initially started with 2 against each. And as we've iterated that process over the last 2 or 3 years, there was a real feeling that we needed to bring it down even more. And so that exercise led us to 1 high-level priority for this year against each of those. It was really interesting in the development work that some staff had even said, let's just go for 1 priority. And we were almost persuaded by that, but it was a feeling that we're maybe a step too far. Now, the point of doing this exercise, and it really touched on what we heard from Boc earlier on, is how do we sit at the board level and agree the strategy for the organisation, but find a way of making it meaningful for all of our people. But more importantly, once they've got that meaning, how do they all put their shoulder to the same wheel in order to be able to move things forward? So an exercise called Catchball takes place, where these are largely shared with our senior teams, who then reflect on what's been prioritised and pass it back. They in turn then share that down at the next level. So we kind of cascade through. What people will see from figure 2 in the pack is the representation of our 4 agreed priorities. And as we know, when we run such diverse services and we have such diverse functions within it, these are by nature high level that really look to align people rather than very specific and smart. And so the process of cascade that is spoken about in section 3 really then takes us to how do we align those high level purposes down to right the way to people's individual priorities for the year. So you'll be able to see in figure 3 that sense of cascade. Our agreed priorities are on the left, moving through those 4 strategic goals each year, and then looking at divisions, departments, and right through to individual priorities. And we're tweaking our Grow Together system this year to mean that it will drive a model that says every member of staff in agreeing the priorities will have to have a personal objective, 1 against each of those, as well as 1 against a range of core business as usual functions. So you'd expect a department manager, as well as focusing some of the strategic direction for the organisation, to be understanding their responsibilities around budget management and making sure they're leading their people and delivering the outcomes that they would expect. So it tries to tie in a strategic focus as well as a more day-to-day focus. What we would expect to see in those individual priorities and those department ones are more punchy metrics. And that's how through our regular performance meetings, we look at and talk about where the progress is made. But we've included here what we've called some North Star metrics. And these are things that broadly align with our 4 priorities so that we as a board on an annual basis can have a look and seeing, are we getting some confidence we're moving some of these. It's not an exact alignment, but Anita's already mentioned we're due to get very soon the next year of the staff survey results. So again, that will allow us to track a number of these measures a bit more fully. Alongside this, and this element of the production system is the daily rigor and management. And I've already mentioned it as part of our transformation program, but it's really then aligning this with supporting teams with the ability and the tools to be able to improve on a regular basis, to be huddling with their team to talk about the things that have been identified as mattering. So that's an overview of where we are. It's just building on what we've approved as those high level boards, but to give you assurance in some of the roll through process, because we are getting very close to the 1st of April, where we have our cascade of appraisals. So initially senior leaders during April and then rolling through tiers, so that again, we try and get that sense of alignment, so that when I agree on my objectives with Anita and I sit down with the executive directors, we're able to make sure there is alignment and so through the organisation. We've brought it here with an assurance rating of partial, and the reason for that is we are still relatively early in this process, about 3 years in, and I'm finding it frustrating. We've not got it completely nailed, but when I talk to people externally who've been doing this work for many years, they're kind of praising the speed with which we've done it, and they say 10, 15 years in, they've still not got what I would dream of with this beautiful line between the board and every member of staff. But we know in some areas, for the last couple of years, there are frontline staff who have really clear aligned objectives. It's up on the wall in the department and they can understand it. In others, people are still getting their heads around this, and it's being worked through at care group level or a divisional level, and we've still got to go further. So that's why partial assurance has been offered, because it's the consistency rather than we can't point to pockets where it's been done directly. But I do think the change to the Grow Together approach will allow us to hardwire some of this in a way that means it becomes a bit more mandatory than optional, and therefore running the risk of being one too many things to think about. So I say this is all Kevin's work of what was intended behind the paper.
Thank you very much, Adam. Any questions or comments? Richard.
Yes, thanks for the introduction, Adam. I think this is really important. So some people might see this as a tick in the box exercise, but it is really making an impact if you do this well. The critical success factor, however, is that people do it with the right quality, and we execute it down to the lowest levels in the organization. And it's not just to make sure that people are working aligned to the corporate objectives. It's also that they understand what does success look for them themselves, right? It's giving them something in their hands to say, yeah, I've been really successful at the end of the year. I agree with you. I've done similar processes. It takes a couple of years to get it right. So I'm really interested in how we are going to determine whether we've now done it well enough in all the areas of the hospital. And so how do we get some assurance to get from the partial to substantial assurance over time?
Yeah, thank you. So I completely agree, Richard. And I think there's something about compliance and there's something about quality, as you say. And I think last week, we asked all the divisions and corporate teams to share their versions of where they've got to. So as a senior team, we went through and people shared and critiqued, and as a kind of learning exercise. On the basis of that, we've agreed we're going to come back next month with the iterations that people are reflecting. So I think we're seeing some quality through that. I think some of the compliance issues will come through the new Grow Together review, but also when we put it alongside our accountability framework and have our regular performance review meetings, I think that then we'll have some of that challenge in there. That the intent at the moment is that we will put something out, probably using our kind of budget manager list as a reference to seek assurance of compliance against those. But again, trying to use our divisional cascade and those people who've learned more about this through our leaders program to be able to work with their direct reports to make sure that in the same way that even at a senior level we've been having to work through and get our heads around, that we are guiding people through the pathway. And so I think the compliance bit is the thing we should really make sure we've got. I think the quality will iterate in this year into next year, etc. But I think we're at the point where we can really insist on compliance of the approach. The team, Kevin particularly, has produced kind of guidance to help people do some of that, but I'm sure it won't be where we need first time round.
Can I just build on that slightly? because I forgot to say, and that I think the crucial element in this is to also really train people. Objective setting is far more difficult and requires more time than you think. And so I understand that the senior layers have been going through this leadership development type program, but it really needs to be cascaded further down. So has that happened? Do we have a plan to make it happen, etc.?
Yeah, so I think that there's two strands to that. So yes, the leaders program started because I insisted that the most senior leaders modelled and understood. We're now getting some relatively junior staff going through the leaders program, including kind of PA type of level. So we've got a lot of people going through, and I think some of that knowledge gets shared. But we're also rapidly building what we kind of brilliant basics program, supported by what does good daily management look like. And so I think some of that management development rather than leadership development as well is currently in build, and this will feature as part of that.
Yeah, thanks Adam, thanks Richard. I completely agree. I think actually so much of what we need to do is going to be about making sure that our grow together process is as resilient as it can be, and that therefore people do know how to set objectives, how to measure them, how to if necessary hold people to account, and so on. So I think that's going to underpin an awful lot of what happens over the next year or two. Diana.
Thank you, Chair. Adam, I think that, as you say, the report is really comprehensive and it really points to a lot of good practice that's going to come out of some of this work. I'm just wondering, how are we capturing that and maybe perhaps sharing it across, areas of the trust where they need a bit more help and support?
Yeah, so I think this in part plays into what I described the session we had last week, and then having another session next week. It was very much at that kind of divisional team layer, sharing from division to division, and we got some real variability where some people had really latched onto what they felt landed very well. Other people were actively grappling with how to do this. The next bit of the cascade is then the divisional leaders bringing their care groups together. So I think we're going to start to get that kind of cascade of sharing through those streams. We will need to consider, and we might do this through our kind of leadership live events, how we bring the community a bit more broadly together, so we can link a care group in cancer division to one in women's and children's. But at the moment, I think on a pragmatic level, it's about how do we get that learning across divisions and across corporate functions, because we recognise that it's really important for the corporate teams, because they are quite diverse so if we take Martin's directorate, as well as we can talk at finance and business intelligence, but within that, finance is made up of a number of different functions that will all have different areas of priority. So we're really encouraging that sharing at that layer down, so that people really do learn from each other. But I certainly felt in the session last week, people really came out of it quite challenged by what they saw from others, and their thinking was challenged in terms of how they make this more and more meaningful.
Thank you. Janet.
Thank you. I guess this is more of a sort of plea than a question, really, just given everything that's happening with transformation journey that the trust is on as well. It's just really, how can we simplify this and simplify the tracking of it to make it as easy as possible for people to deliver what they need to deliver, say from a transformation perspective, but also hit some of the targets that are being looked at here. And I kind of echo Richard's comment about training and really understanding and boiling down exactly what is that conversation that needs to happen. What does that look like? Keep it really simple, not spending lots of time kind of wordsmithing and sort of feeding the beast, because the system is one thing, but the really rich conversation and the nudging people to change their behavior in the flow of work is a different thing. And I think we don't want people to over-engineer it from a system point of view. We want them to just get on with what they need to do and not feel sort of overburdened, really.
Yeah, I'd make two comments. One very much in support of that. One maybe challenging a little, because I think that it's a big theme for us. We spent some time as an executive team yesterday, and how we manage in a world where constantly more and more is being piled on and actually this came through as a really important tool for us. If it's not in line with strategy, we might have to say no to things, because otherwise the risk is what we've identified as most important doesn't get done. So there is a useful tool in there, and I think I completely agree. And I do think the beauty of the Grow Together route and hardwiring it in, people are now familiar with that, and we've seen much more positive feedback this year than 3 years ago when it was all a new system. So I think that helps. The only bit around the let's not spend too much time in wordsmithing getting on. Actually, what we've also heard is people have found real value in the conversations of developing it, as much as they had is, well, we've agreed that let's just get on and make it happen. So it's striking that balance. And I certainly found last year spending some time with a paediatric team who, based on staff survey results and what were coming together and really spending time in conversation, and some of the very junior staff, they're involved and really kind of feeling, oh, we've actually got a say in shaping this. And so I don't think we should underestimate the value. And I know that's not what you're saying, let's not have any conversation, but it's finding that sweet spot between we can't navel gaze forever, we've got to get on deliver, but also let's get people involved, because I think it maximizes the chance of this success. And going back to Bok's early comment, a real sense of I can see where my purpose aligns. And I said earlier on about the importance of the corporate teams, and for me it is really important that we make people in the people team or the payroll department really feel that sense of connection with the brilliant stuff that we as a board get to see our frontline staff do every day.
Yeah, no, I completely agree. It's the old janitor putting somebody on the moon, the apocryphal story about NASA, isn't it? But it does hold true, definitely. Thanks, Adam.
Yeah, Teresa.
I think it's really good to see the agility of the production system adapting and evolving to support, our care support workers, our ward managers, because they are the teams that run our clinical services. And I think it's really reflective of the fact that we'll see a lot more innovation, I think, at every touch point through those inclusive points you've just raised, Adam. The fact that we are using the production system, and that's emboldened and embodied in everything that we do, because I think that's the differential, is that inclusivity of every single team player in the clinical environment. So I'm excited about the future. I know that our ward managers start their new programme with the production system, in fact, this month. So we'll report back, I'm sure, at a future committee about how interesting and compelling that will be.
Brilliant. Thanks, Teresa. And yeah, absolutely. And I think we're bringing together a number of little bits of the jigsaw that I think are absolutely can work together to build a big picture. So no, lovely. Adam, thank you very much for stepping in to cover that. As Adam mentioned, this has been suggested as a assurance level of partial. And remember, as we've had the conversation before, our assurance level is based on the processes around things rather than necessarily where we are today. How are we comfortable with partial? Do we think that's mean? Do we think that's generous? To go one up would be reasonable. To go one down would be minimal. I doubt very much we're at minimal. How do people feel about that assurance level? Partial. Justin's nodding. He's in favour of partial. Get a few nods. We're happy with partial. Thank you very much. We will accept that assurance level. Moving on then to our next paper, which I'm delighted to see Amanda and Francis here with us, and it's about home births. Over to you.
Thank you, Chair. I'm going to hand straight over to Frankie Kilmurray, who is one of our consultant midwives. She runs our Birth Choices Clinic, and she's led on the audit and response to the Prevention of Future Deaths report that has come following a very sad case from Manchester Foundation Trust. So I'll hand over to Frankie, who'll just take you through the key points from the report that's been shared.
Thanks,
Amanda.
Frankie. So in response to the coroner's report where a mother and baby sadly died after a home birth, there was a call for immediate action and learning, and also our chief midwife wrote to every trust that actually we need to give assurance on our services. And the services we need to give assurance are on our home birth, so the operational running of our home birth service, bearing in mind the equipment our midwives use, the fact that the home birth rate has decreased nationally and sits about 2%. So when midwives work on call, how much experience are they getting with intrapartum care, because they might only go to 1 or 2 home births a year. And also it's around outside of guidance care and that counselling for women choose care outside of guidance and giving assurance on that. So the case was the mother sadly died and the baby sadly died. I won't go into all the risk factors, but you got that in your pack, but there was learning across her maternity journey. So in terms of our service assurance from our birth options clinic, we have a birth options clinic in place. I think it's important to understand the context that midwives work in, where accessing home birth is a qualified human right, so that we also have in our NMC code a need to attend any mother that asks us to when she's in labour, wherever she is, unless there's a reason from a service perspective to mitigate that or a staff safety concern. So what we're always trying to do is ensure that when women choose birth plans outside of guidance, that they have informed consent. They hold the responsibility for those choices, but we work as an MDT team to counsel them, ensure they have the information, the pros and cons, and even the explicit risks, which sometimes are rare, but can be risks of death and brain injury. And in terms of our home birth guidance, the slide shows some of the assurance around every home birth has a full risk assessment undertaken, and things like the birthplace study outcome data is discussed. And also we have good guidance in place for when we transfer in when complications develop at a home birth. In terms of our slide on governance and learning from home birth, we haven't particularly had any moderate harm cases around the home birth process itself. We are also seeing nationally more women choose to give birth unassisted, which again, they can choose to do. And we've found in a few of those cases where, of course, it's mum's rights and the baby doesn't have rights till it's born. At point of once the baby's born, maybe not that translating into realising that the baby now has its own set of rights, and we're working closely with our safeguarding teams to support these women, keep those relationships open as much as we can, so they will engage with NHS care if they feel they need it, but also weaving in that safeguarding alongside that. In terms of audits, so we've now had audits on out of guidance on the home birth service, and our learning from the last year. There's been strengthening of pathways around equipment that the midwives carry, because each midwife has to carry a full set of equipment for home births because we cover quite a large patch. Improvements in the monitoring of the baby's heart rate, which is supported by fetal monitoring leads, and increase in our documentations. There are ongoing barriers with our EPR, and also the challenge that we work cross boundaries. And also what's shown in the coroner's case as well is that process for results checking when women access urgent services like our triage service, and getting that timely review. So in terms of local actions, we're going to set up a task and finish group. We've undertaken a full gap on the coroner's case to really try and learn as much as we can for it and reflect on where our gaps are. So we have assurance on the basics, but actually what can we do better? We really want to use this as an opportunity to improve, to put more sort of standard operating procedures around home births, how the midwives are called out, how long they're going to work on their on-calls. Things like the maternal care bundle has just been released, and that has elements for improving safety in the home, especially around postpartum hemorrhage, which was a factor in this case. So it will always be a challenging area for us to work in, and in a way it's getting more polarised with people wanting more outside the box. But we have to support maternal choice, and we work really well and proud to work with our obstetricians here for supporting that choice and that MDT counselling. So we can give you assurance that locally we do have that oversight and we are looking at this, but actually we want to do more, and we'll be setting up a task and finish group to really strengthen our pathways around outside of guidance care and home birth.
Thank you, Frankie. Apologies, I called you Francis because I could see your name at the bottom, but yeah, thanks, Frankie.
Officially.
Yes. Okay, lots of hands going up. So, David.
Thank you very much, and the board will know that we've discussed this paper at QSC. And just for the public record, I don't want anybody to think that I'm against home birth. One of my 4 children was born at home. But what I am against is people taking really unnecessary risk because they don't understand what's involved and the scenarios that could occur. And I think risk is a difficult thing for all of us to wrestle with. But if it's your first home delivery, you know, understanding the risks must be quite tricky. So I think this is the most important upstream thing. And you have, Frankie, you have touched upon this on a couple of occasions. But how do we as a trust really have confidence that those women who choose and want to have a home delivery really understand the implications of that? Because I do think it is difficult to do it in one 20-minute discussion.
I think it is a challenge, and I think Justin has given us a good check and challenge, because actually there are different outcomes for having your first baby at home. Only slightly increased risk, but your baby is more likely to die if you have your first baby at home. So the risk assessment on our EPR is very, very thorough. We do try and undertake that in the home and have more time for that risk assessment. You can also then assess the environment, think about things about extraction and emergency. It is quite explicit around the risks that can occur at home birth, and also uses the birthplace study data to try and compare that to other birthplaces, especially compromises.
Frankie, apologies for interrupting. I know we do a thorough risk assessment. It's just how we translate that into something meaningful for the person who's making the decision.
So there's a good tool from the birthplace study which actually compares outcomes across midwife-led units, consultant-led units, and home birth, depending on if you're having your first or second baby. But anyone that has a risk factor outside of guidance would be referred to Birth Options Clinic for onward counselling with myself and as needed. I didn't catch that, sorry.
David, I think you are breaking up a little bit. So I think you've frozen. Yeah, I think you've frozen. Okay. I think, Frankie, you addressed David's question. He may come back in if there was something he wanted to know specifically. But let's move on to Teresa. Thank you.
Thanks, Chair. It was an excellent paper, Frankie, and a really clear presentation. There's always this tension, isn't there, between individualised care and trying to have that wraparound safety net. I thought what was really interesting is you touched on informed consent, but you talked about it in a dynamic way, and I thought that was really helpful. And you also talked about risk and monitoring together, which I thought, again, gives me a sense of this is not something that happens once at the beginning of the women's journey. It's going to happen continuously as we monitor this particularly vulnerable group of individuals. And I think the final point I just wanted to make was there is a real need to dedicate time and specialist midwives and obstetricians to those individual women. And I just wanted to quickly ask, how confident do we feel that we can do that and have a line of sight into each individual woman? So have we got the capacity and the scope and the capability to maintain those standards we've cited?
Thank you. Yeah, I think you make a really important point. And in maternity, the risk is always evolving, and that's woven into our staff training that actually these risk factors can develop at any point. And the coroner makes the point, actually, the pregnancy was low risk. It was at birth she becomes high risk, but even in labour, you get these risk factors developing. So we're always risk assessing, we're always counselling for those evolving risk factors, and they mean different things to different people. So there's an art to it as well. We have education for our staff. We're using national resources performers, strengthening the website. But in terms of resource on auditing the Birth Options Clinic recently, there is enough appointments for the women that need them, and they have stayed quite consistent. I would say there is a challenge around midwife time and how much time community midwives get with women with what we're commissioned for, because I think if community midwives had longer appointments, they would have much more time to counsel for these things. And also they should be doing it, like all midwives should be able to counsel to an extent and then access us for support for the sort of more headline cases. So that is a consideration, is how much time our midwives get with people, not just to do the task like an antenatal check, to really spend that time and listen to women and talk to them and provide them with information.
Thank you, Teresa. Richard.
Yes, and thank you, Frankie. I've got two questions. One is, since the amount of home birth has reduced so much, what's happening to maintain the competence amongst the midwives to still do it? And the second one is, of course, we're not alone in all this. So in terms of thinking about your improvement plan, to what extent have you also talked to other trusts, share experiences, best practices, etc.?
Thank you. I'm going to go backwards. So in terms of sharing our gap that we've done on the coroners, I took to the Regional Consultant Midwife Forum, and we're really trying to work together on these things, and especially those pathways around unassisted birth as well. So we're really trying to share in the national team has set up a group, and we'd love to be part of that if we get selected, but we'll be definitely engaging with that. And yeah, there's good forums out there. In terms of training and skills, we have good training packages and emergency skills and drills training, but this year when we're mapping the training programme, we want specifics on emergencies in the home and communication, and there's also planned work to try and have a joint study day with the ambulance service, because this case also showed at that point of transfer that joint working with evacuation from the home and when there's a home birth emergency. So yeah, absolutely a focus on training and competencies. And I think we have to really look at how our services work as well, and actually how much, who are the right people to be attending home births, and who are the experts in that quality intrapartum care, and of the different models of care that we'll be exploring around. Now we do I've started a model where we send our midwife-led unit midwives out overnight as a second to the home birth. So actually they're providing labour care all the time, and there's that sort of strengthens that people have regular exposure to the intrapartum care.
Great, thank you, Richard. Justin.
Thank you. And I want to say a massive thank you to Frankie. We're really lucky to have her in the organisation, to have somebody with such expertise in this area. And it is a really difficult area because the proportion of women having home births are low, but we have to maintain our expertise in this, and we have to do this well. It's, as Frankie said, it's something that's nationally mandated. I wanted to try and offer a little bit of assurance to David around his comments. We talk very extensively, and Frankie and I have discussed this a lot, about what the risks are. And the risks to a first-time mum choosing to deliver at home are roughly double the risk to delivering in hospital of the baby dying or having a severe neurological outcome. Conveying those messages is difficult. We don't want to scare women. We want them to understand the risk, and we want them to make their decision from a point of knowledge rather than a point of ignorance. This is not an easy area to get right. We operate in a system where we have to provide this service, and it's right that we provide this service. But I think that the service that we're providing within the trust is one that is as safe as it possibly could be. And I'm really reassured by the work that Frankie has done and her team have done, and the response that we've put together to the Prevention of Future Deaths notice from the coroner in Manchester.
Thank you, Justin. That was helpful. Final question, Kevin.
I do apologise, Chair. I'm not used to this. It's a new computer, as I said earlier on. It doesn't seem to be wanting to work with me. Just on a non-technical thing, I'm just looking at this and from the outside, looking at the comments that have been made, and Justin just said, you know, the risks are double, but we've got 100% compliance achieved with regards to the risk assessments undertaken. And given that we have to give this choice out, at what stage? I mean, with the local, the locality, the environment, that all these things become more and more difficult and go into the risk assessment. How can we? I mean, what is our level of duty and responsibility with regards to at what stage do we turn around and say we can't countenance this? That might be a silly question, but at some stage, if the environment is not right, or we don't know, or the distance is too much, whilst we're doing the compliance at 100%, the risk factor, where are we? What is our duty and responsibility as a trust?
Yeah, thank you. Great question. We've had some good examples of that in the last few weeks. So We have to send our staff to a safe workplace. So home birth is a qualified right. So if it's not safe to send our staff, we can go from that perspective. But what we have to think is then we open up the woman and the baby to clinical risk, and we don't sort of want to shut the door on them. So it's a real balancing act, and most of the time it's fine, but there are some headline cases. I mean, we've had a birth on a boat which you had to cross a railway line a few years ago, which had a full risk assessment with support from health and safety. And more recently, thinking about, is a home a suitable environment? There's been really close working and MDTs with safeguarding, with your colleagues in health and safety, and even the legal team, to actually look at, is it reasonable for our staff to provide this home birth? But if we're not going to provide it, what mitigations can we put in place to think of the clinical risk we're opening up that mum and baby to? And again, we're always looking for options for compromise, and our midwife-led unit really offers us that. If we can invite women in to have that home from home with their risk, like environment, but they're in hospital if they need the teams.
I was just, if you don't mind, Chair, I was just trying to think of something within my own personal remit. If someone said to me, you are doubling the risk by doing something, at what stage would I say, I'm going to do it anyway?
It's so personal, and everyone has different motivations
I agree.
And different histories that influence why they want to give birth. So it's really personalised care.
Yeah, I think Amanda wants to come in, and then we'll bring this one to a close. Amanda.
Yeah, I think the difficulty here is trying to convey a risk where the risk might be doubled, but that ultimate risk is still extremely low. So it's about giving women and families the information that they need to be able to make that decision with all of the information, understanding that level of risk, but also translating that level of risk, while it's double, still remains low for the majority of women that are choosing birth in a home birth environment. I think really to summarise, sort of from my perspective as Director of Midwifery, in this terribly sad case, there was a midwife who was very junior, who had been working a very long time, over 24 hours. There were failures with equipment, there were delays in terms of activating emergency protocols. I think with the work that we've done locally and engagement with the regional work, we can give really good assurance of the processes and pathways that we've got in place as an organisation, and a commitment to that continued focus, recognising the important point that you made, Richard, around making sure that our staff, with a reducing home birth rate, maintain those skills of high risk care. And when things can go wrong in maternity, they can go wrong very quickly. So it's making sure that our staff maintain all those skills to equip them for such situations, and that's very much the focus of the working group which Frankie's leading, and I'm very grateful to her for all the work that she's done on this project.
Yeah, thank you, Amanda, for that, and for a really good discussion. Frankie, thank you for that paper. It was an excellent paper, and I think we all understand it's a really tricky area. We want to respect and support the rights of the mother, but sometimes the rights of the child may not be aligned with that, and therefore it's always going to be tricky. But appreciate the work on this. So board colleagues, this paper it's proposed a reasonable assurance for this paper. How do we feel about that? Are we happy? Reasonable? I'm seeing some nods. Okay, great. Thank you, Frankie. Thank you, Amanda. Great. We are running a bit behind time, but I think we can pick up from here. The next paper we have relates to our board assurance framework, which normally Stuart would take us through. I think as assuming the paper, if we can take it as read, we know that there are a couple of risks that have increased to 20. One around financial constraints, the other is around system instability. But I think also we had a spotlight this month on two risks that related to Penny's area. So I wondered, Penny, if you just wanted to make a couple of comments about BAF risk 4 and BAF risk 5. Thank you.
Sure. So I'll take the one around workforce morale while making change. This is certainly, as I'll go on to talk about in, I think, one of the next agenda items, our overall performance review. We're going to continue to change and evolve over the next few months or the next year, I would say. And it's an area that we've paid particular focus to in how do we continue to change and evolve and create efficiencies while taking staff with us and also doing that in the best possible way. We're in the middle of an audit at the moment, a change audit, which I hope is going to give us some really good qualitative data as to how managers feel when they're going into change and how they do it well. Feedback so far that we've had is more time just to develop ideas and more time to engage staff are two things that are critically important, and we've already started to work on those. I think we have made some progress. I won't say too much about the staff survey in this meeting because I suspect it will be a proper board agenda item in the next one. But there are areas where we have gone down, but equally that we've gone up, and we can see that what we're doing now is starting to give green shoots. I think we are, and it's linked actually to the second risk, which is about leadership. We are paying far closer attention and working with colleagues in our staff side to understand how we do things better, because what we can't promise is that the pace or the scale of change is going to slow, but what we can make a commitment to is doing it better. So I think that kind of touches on both the leadership and the workforce morale. On the second one, the increase was, I think, related to a conversation with non-exec colleagues around making difficult decisions, and we spent some time yesterday as an exec talking about, is that really the issue, that we don't make difficult decisions, or that we don't give ourselves plenty of time to implement them, so we rush from decision to decision without fully implementing what we've talked about. And so there's some work to be done on that, which is why there's seen a slight increase. So I think overall, I would say that we have made some positive progress. We certainly haven't taken our eye off the ball. I'll perhaps focus on that when we talk about the staff survey in the next board meeting. But yeah, I'm happy to take any reflections or questions if that were appropriate.
Thank you, Penny. We have Jill.
Thank you. I wanted to talk particularly about the risk number 5, leadership and engagement, and this is so predicated upon our need to model the right behaviours, isn't it? And cascade that. And I was reflecting upon the discussion that we had earlier around strategic goal cascade and how that really evidences that work being led in a way that we desire and in an impactful way, which is really, really positive. There's a however, though. However, the detail of what we have in front of us is, again, a score that's considered to be increased, with the controls identified mainly as, assurance level 6, everything, achieving what we want. So there's something amiss here. And I suppose it was just a suggestion that, and one maybe we can give some consideration to outside the board meeting, but whether this would be really beneficial for us to spend some informal time exploring further, because the nature of our leadership is going to be so germane to our success and delivery of strategic goals and objectives within the environment that you so rightly described. The pace isn't going to let up, the complexity isn't going to let up. That this is really, if there was one thing I think we need to focus on authentically, it's probably this.
Yeah, I think that's fair, Jill. Thank you.
Yeah, thank you. Karen.
Yeah, I also wanted to have a look at risk number 4, which is the one to do with workforce morale. And on this one, I was sort of, I sat back and I thought about what we've still got to do. So if we look at our productivity, we know that it hasn't increased in the way that we wanted it to. and we know that our workforce numbers have continued to increase. We also know that we have indeed been putting in place controls to work with that, and that we've got a detailed transformation plan that lies ahead. But I just wondered whether, when we looked at this particular risk, whether we'd almost just judged that it was working before we'd actually really got into the work in as much detail as we need to. So I think it's one where we're doing okay, but with staff morale, and I think it's something that Penny's been talking about anyway, as we begin to look into what we've still got to achieve, I think it's really important, and our strategic plan helps with that as well, that we actually have that eye to morale in areas across the hospital as we actually undergo change. So it's a long way of saying, I'm just not certain that it's right to reduce the risk score on that at the moment, and whether we shouldn't be looking harder at whether we've got more controls that we need to put in place for next year as well. So just a little bit of a challenge on that one.
Yeah, no, I think that's fair, and I think this is probably considered prior to us looking at the coming year. So it's, you know, where are we now? How are we doing? Not so bad, actually, if we look at the coming year. But you're absolutely right. I think some of the actions could perhaps be tailored more specifically to some of the transformation and the so what, or what might be the outcome or the impact of that, and what are we doing about that. No, I think that's a fair point, Karen. Thank you.
Yeah, I mean, the only point I'd make is, you know, as we know, these risk assessments in the BAF are dynamic. So they are supposed to be, you know, responding to where we are at any given time. So I think it might be, you know, and yeah, I'm not going to get into the detail whether it should have gone down now or not. But I would fully expect, Karen, to your point, that, you know, as we get into some of the work that is going to be coming down, I think that it is highly likely that the risk rating will go up in this area, because it would seem to be inevitable to me. But I think it's right that we keep it as a dynamic thing, because, you know, that's the only way we can really do this. One final comment from Janet, and then I think I need to bring this to a close. Janet.
Yeah, thank you. I think that, you know, to Karen's point and to what Penny said, this was very much looking at coming out of a lot of the administrative review that was going on, and some of the challenges that had been related to that, and then also some real worries around the Mars scheme and the loss of kind of key personnel within that. And I think we'd kind of looked back at that and thought, well, things we got right, things we didn't get right. Actually, we feel on balance that we can reduce the risk. I guess if we don't reduce it now, are we truly going to put it up even further when we start looking at transformation? And I think it's to your point, Anita, about it being dynamic. It's a tricky one, because to me the risk is always there. It's much more about how do we handle it, how do we learn from it, and therefore how do we mitigate it, because we're going to be we're, as we know, in kind of perpetual transformation, really.
Absolutely. Thank you for that, Janet. Okay. Now, the paper, which doesn't relate just to the two HR BAFs, but to the process of the BAF setting and review and on our processes, proposes a continuing reasonable assurance that we have the right processes in place, the committee reviews, etc. Are we happy with reasonable? Does anyone wish to suggest a change? Reasonable? I'm getting nods. Okay, we will accept that assurance level. Thank you very much. Right, we are running about 10 minutes behind, but I'm also really conscious that, especially on a Teams meeting, we really do need to be able to get out and have a quick bio break. So can we please take a 10-minute break now, coming back at 11:10, and we will kick off with the IPR at that point. But can we be a little bit crisp to get through, because I also want us to have a lunch break later as well. So back at 11:10. Thank you. Right, so moving on then to the next item on our agenda, which is the Integrated Performance Report, and I'll hand over to Penny this month. Thank you.
Thank you. Thanks very much. So I'm going to start and I'll give you the highlights from all 4 quadrants, starting with quality. And we've got some positives in this particular area. We've seen a reduction in the amount of hospital-acquired infections to the tune of around 25% in this performance period. And where we have had flu outbreaks in the wards, they've been very well managed by teams. So that's a positive story to start with. We've also seen some improvement in our numbers of patient falls. In previous boards, we mentioned that there'd been a spike in December and January in patient falls, particularly in kind of the bathroom areas. And so we'd undertaken a deep dive in that. I'm pleased to report now that we've seen a reduction in patient falls. It's fair to say that none of the falls that occurred in January and December resulted in significant harm, but nevertheless, it's something that we have been looking at, and that's now starting to decline. 2 other areas I'll cover are sepsis, our sepsis protocol, and blood clots. First, in sepsis, we've made some improvement in our sepsis protocol in relation particularly to IV antibiotics. And just call out colleagues in the emergency department who are really prioritising kind of looking for early signs of sepsis and then prioritising patient care, which is making a real positive impact. So just to kind of commend the efforts there. And finally, I mentioned blood clots. In every ward, we have a patient safety board, and blood clot risk is now on that. So again, we're seeing some kind of green shoots in relation to the quality area. Just moving on to operations. Fair to say we've seen the highest number of attendees in our urgent and emergency care department. Coupled with high attendance, we've also had to undertake some emergency kind of estates work, which has taken out a couple of beds. So both of those things have contributed to our performance not being exactly where we'd want it to be. And we've looked at 4 and 12-hour performance, which is just slightly behind trajectory. That said, over the last couple of weeks, we've implemented improvement sprints, which are multidisciplinary teams coming together every day to try and identify problems and solutions. So hopefully at future boards, you'll hear the progress of that, and fingers crossed that will be an improved level of performance. We continue to show really strong progress in cancer. And both in December and year to date, we've met 3 out of 3 targets. So that's a strong area, and it continues to be a strong area for us. In RTT, so referral to treatment, we continue to be in the upper quartile nationally for both 18 and 52-week sprints. And our diagnostics is another area of improvement by 2 percentage points, and we now sit at 51.5%. So both of those areas are really tracking some either green shoots or some improvement. If I move on to the area of finance, I think it's fair to say we've got some work to do, and we have a continued focus on our financial performance. Month 10, we saw a deficit of 4.6 million, and looking at year to date, we are below where we expected to be or would hope to be in relation to our savings target. So it is a real area of focus for us every day. In relation to why that might be, we have had some unanticipated spend on bank and agency staff, but there has been an awful lot of work done to try and plug the gaps where we have got high recruitment needs. We've been running, particularly just before Christmas, and we're now starting to see people roll on. We ran some assessment centres for staff where we were seeing bank and agency numbers going up. And we have just recently implemented some rota changes to ensure that we now start to look at the demand of where patients need us to be and the supply of staff. So some work on that is already starting to bear fruit in that we can reduce our bank staff and we can rota our own staff in to be scheduled to work when they need to be. But it's an area of focus. And the final quadrant is people. And there are a couple of metrics that indicate the health of an organisation. Turnover tends to be one and absence is another. In turnover, rather than a target, I'll call it a threshold, we have a threshold of 10%, which is what we consider a healthy turnover figure. We're tracking just below that, just shy of 8%. So we're below our turnover threshold. In relation to absence, it's a slightly different story. Our threshold is 4% and we're tracking just below 5%. And I think very much linked to the earlier conversation on some of the risks, we're seeing an increase now, a slight increase in work-related stress. So consider the kind of seasonal increase with coughs, colds, flu, and the work-related stress, and we are nearly a percentage point over our kind of threshold. And I mentioned earlier that we are doing some work to understand better the reasons behind that and how we can make change, give people a better experience of change to try and impact on that target. I think the final couple of things I'll say in the people segment is that we mentioned earlier the importance of Grow Together reviews, so annual reviews, regular one-to-ones, and also completion of statutory and mandatory training. Often what happens when people are busy, the things that are not absolutely urgent and top of the list fall behind, and so we're slightly behind where we'd expect to be in our Grow Together reviews and also statutory and mandatory training. But again, it's something that we're working on to create time and space for people, but also to make the process as agile and lean as it can be. So we're only asking people to do training that they absolutely have to. So I think if I were to sum up our month in performance, there are lots and lots of areas of improvement. There are some green shoots. The area of focus remains finance and savings and efficiency, but also very mindful as well of doing that well and the impact on our people. And I'll stop there and take reflections and questions.
Thank you very much, Penny. So obviously we are going to go to the individual committee chairs shortly to talk about specific elements. But if there are any general comments or questions, we'll take them now. Jill.
Thank you. I'm keen to sort of understand the degree of triangulation, I suppose, that the execs have considered or may be considering. So I've two questions along those lines, if I may. The first is sort of, is there any correlation? Have the execs identified any correlation between, you know, some of the safety indicators that we're tracking and perhaps other areas experiencing highest sickness or bank usage? That's that sort of correlation. Has there been any is there any knowledge or exploration of those connections?
I don't know, Penny wants to come in, but I see Teresa has come in, so maybe I'll unless Penny, you wanted to say something.
If I let Teresa go and then I'll come back to it, Jill, if that's all right.
Brilliant. Teresa.
So I think that's a great question, Jill, absolutely. And so I think some of the areas that I could focus on is where we've not been able to, say, run additional lists, or we've not been able to open all of our sort of extra capacity facilities because we have been limited by the number of staff available. That's one of the areas where you'd be looking at the sort of triangulation around effectiveness, flow, and also quality, I would say, in that area. We have got to be really mindful about the fact that, you know, when we're in extremis, we've heard about the numbers being phenomenally busy. Of course, it's the same team of staff that are dealing with these pressures. So you would expect some of the indicators, you're absolutely right, Jill, to change. I'm very proud of the fact that, you know, we've managed to sort of reduce and control our hospital-acquired infections compared to last year. But, you know, if we don't manage the sort of workforce well-being, stress, etc., then you could see that indicator, and in fact, all of the indicators could change. The number one I just wanted to raise is around our specialing. So where we've seen the impact on having availability of specials nurses, that can have a big impact on patient falls, etc. So we're not quite there, Jill, but I absolutely hear what you're saying, and we've got to be mindful of that.
Okay.
Yeah, it's a really important connect that those connections are made. Justin, did you want to come in on that point, or was yours a separate point?
No, it was the same point, and I guess it was a bit of a further answer to Jill's question. It's a really good question, and it's a really important question. I think it's one that we've spent quite a lot of time as a team thinking about. A couple of areas I wanted to pick up in response. One is that we have run a number of staff consultations over the last year. We've been mandated to make a number of changes to our staff, but also there are other changes that we need to make to keep our organisation going in the way that we want it to. Those have caused pressure on staff, and we know that in the areas where we have had consultations and where people have been worried about losing their jobs, I think that's had a direct correlation with the amount of sickness in those areas. And that's something that we need to think about very long and hard. And I know Penny's been doing some really significant work on how we could do this better in the future. The second bit I wanted just to pull up was the work that we're doing on violence and aggression. We know that where staff are affected by a violent incident in their work, they are more likely to go off sick either through physical reasons or through stress reasons. And I think it's really important that as a trust, we work really hard, and we are working really hard to try and decrease the amount of violence and aggression that our staff experience on a day-to-day basis. And those are both things that you'll be hearing more about in future.
Excellent.
Yeah. That sounds like a good point to bring Penny back in. I don't know if you want to add anything to what Teresa and Justin have said.
Yes, thank you. Just 2 points, if I may. The first is, I think, following on from Teresa's point about having the right level of staff where we need them. We are doing an awful lot of work on trying to match supply and demand, and whether that's in rostering or the right levels of so strategic resourcing. So rather than just wait till you need to recruit someone, if you can look 6 months down the line and see you've got a gap, we can then start to look a bit further ahead. That can take the pressure off staff because they're not then having to cope with less than they need. That's the first thing, rostering. I think Justin's point is well made. We're going to continue to change. What we're doing at the moment is understanding how we can make that the best possible experience for people, which sounds a little odd because when you're going into a restructure which may result in redundancies, you can still take people through in a way that is equitable, with dignity, and actually gives them the support they need moving forward. So while we can't commit to reducing that level of change, what we can say is we can commit to doing it as best we can. Thank you.
Right, thank you. Sorry, Jill, go on.
I was just to say, I really appreciate the richness of those responses. I think that's incredibly impressive to see the connection, actually, which, and unless we have these sort of discussions, we don't get from the paper. So I really appreciate the responses there. That was excellent. Do you want me to ask my second question, or?
Okay, if it's quick. Yes.
Well, it's just a similar one. It's and I've sort of asked this question before about how, it's about how well we're doing on RTT, I suppose, and with looking at the data, with half of our diagnostic patients, waiting more than six weeks, especially for sort of MRI and ultrasounds, so it's indicating. I'm left with a question. So how is our RTT performance remaining so strong, really? And so my question is, are patients waiting longer before referral or diagnostics, or are weights being absorbed elsewhere in the pathway? Is that something that the executives have discussed and we can understand that isn't within the data as such?
Titch, I will come to you eventually, but I think Lucy probably wants to come in on that point.
I mean, I think thanks, Jill, for that question. I think we should remember that our RTT performance is strong relative to other trusts. It's upper quartile, but in itself, compared to pre-COVID, our RTT performance is in the mid-60s%, which means that about 2/3 of our patients at the time, at any given time, and it is increasing by about 1% each month, but, are waiting under 18 weeks, which means that 33% are waiting over 18 weeks at that time. We still have patients, very few now, waiting over 52 weeks for their clocks to close with treatment, but there are still, that's one of the other targets, is to reduce that to no more than 0.7% of our waiting list by the end of this month. As you've rightly said, as we continue to work through the greater challenge in the diagnostic part of our patients' pathways, it will, it will make our overall RTT performance much, much better, you know, not just nationally, but for patients. So that's, you know, that is our most outlying area. We're trying to be very agile between different imaging modalities or different diagnostic modalities to put capacity where it's most needed. And also remember that in our diagnostic weights, the you know, high numbers of audiology patients still are waiting too long as both estates and people changes and investments that we've needed to make are starting to come online. So our diagnostic weights, longer weights, are concentrated in a small number of modalities: audiology, MRI, non-obstetric ultrasound and CT, as opposed to across the board.
No, that's helpful. Thank you.
Apologies, I was on mute. Tishivara, thank you for your patience.
That's okay, Chair. My question really is pointed at Penny, because it speaks to training, specifically STEP Mand. You know, do we now probably have some sort of a qualified impact on training compliance and what that means for quality of work and the culture and workforce stability? I know you touched upon that earlier in your speak, and then I just want to layer that on with an additional facet, which is that obviously as a trust we've adopted the use of Copilot as a tool to assist with everyday work. So my question really is going to speak to the most recent staff survey, which talks about the fact that there's a massive gap in that STEP Mand as a function of online training, which is not being done. And I suppose obviously there's issues around the time to get it done. But, you know, as we move into this really rapidly progressing space, you know, we need to, I mean, not really need to, but I'm just kind of commenting on the fact that we need to start thinking about how we integrate AI into that part of the process. And I don't know if that's kind of covers everything in total, but yeah, that's my question really is about the impact of, you know, inability of us not to reach our compliance levels. What does that do for quality of service that we provide and the culture and workforce stability? But as a sort of like second layer on that is just this idea of the fact that in our most recent staff survey, the gap, especially in a certain people above a certain age group, the STEP Mand is really low because they're not using the online tools that are available.
Okay, Adam, I'm not sure if you wanted to come in and then I can come back to, shall I start now? Yeah,
Can
okay,
you go first, Penny? I'll add on.
Okay, thank you. So just in relation to, so just the first thing I'll say is we do recognise that there is quite a lot of statutory and mandatory training. So we're doing a piece of work looking at, are we asking people to do things they shouldn't be doing? Are we asking them to do it in a way that still works for them? And in when we come to private board, I'm going to talk you through the transformation journey of my team, and we talk in there about how we can match the expectation of our workforce now. And it's not just the older population, actually. We're all more tech savvy, you know, you get your Tesco shopping or whatever on bank online. Everyone's more tech savvy, and we're having to look at learning opportunities for people in the workplace to match their kind of external experience, so to remove the capacity issues. But I think you do raise an interesting point, is around creating the capacity for people to do things that will add value to either them or keep them, you know, keep our patients safe. And I think there's no correlation at the moment that where we're not doing that we result in patient harm. So I just wanted to be clear on that. But we are obviously looking at how we make things easier for people so that we can keep them as compliant as possible. But I have to say, you know, when I joined the trust last year, there's huge amounts of stuff that you do that perhaps you don't need to do. So we're just trying to focus on what's the core of your role as an individual that makes you safe or makes you competent, and prioritise that. But I'll talk a bit more about the digital stuff in our next discussion, if that's all right.
Yeah, thanks, Penny. Adam.
Thank you, Penny.
Yeah, I was just going to make 2 points. One is that a recent news article from a large London teaching hospital really has got into this challenge of where is the evidence base for the statutory mandatory training. And I think the hypothesis is a pretty weak link between the training and outcomes. Now, statutory is statutory, and it's kind of, there's no almost battle to have there because it's in statute. Whereas the mandatory, I think there's some challenge to NHS England about if there are things coming down from the centre, if there's not an evidence base, why would you prioritise that? And there is potentially, we use kind of role specific training in some areas where we think it should be mandatory for certain staff groups, but not everybody. So I think, as been said, that there's work going in that area. On your point around Copilot as a tool that's very recently been switched on, just to say that I've spoken with the admin network around how do we take the better use of AI in personal productivity as an agenda and best spread it across the organisation, because we'll often have a top-down approach, and I'm increasingly trying to teach myself opportunities around Copilot, but I'm also not someone who is doing so many tasks on the system all through the day. So we really think if we could drive the admin teams, both probably being part of the training of that, but also really shaping where the opportunities present. So there's some active work going on. So I hope pretty soon we can come back and maybe even get some of the leaders of the admin network to come and present back where they believe the opportunity and the implementation approaches.
Great. Thank you, Adam. Now, I actually had two questions that I'd be grateful if we could to get your thoughts on. The first one is in the operations quadrant. I know, and it's mentioned in the report, that recently I think Lucy and Justin have done some sort of fact finding around some best practice in UEC, and I know that I think there's a work group or work groups have been established to try and move those forward. I wondered, Lucy, if you could just give the board some indication of when do you think we're actually going to be able to implement some of that learning, because I know you were very impressed.
Yes, thank you very much. And Teresa, Justin and I are working very closely as the exec triumvirate on all of this. We're already seeing the impact of some of that work. So we set the 2nd of March as the beginning of a urgent and emergency care reset, predicated both on learning that we got from Watford, but also recent guidance about new ways of caring for shorten it to a kind of emergency department, same-day emergency care type setting, which the new term for is EMAC, which stands for Extended Emergency Care. Oh, I can't even remember exactly. I'll put it in the chat in a bit, but yeah, that's the new acronym. So our programme at the moment is a blend of the learning we took from Watford and kind of the latest national model guidance, and in March to date we've seen 7.2% improvement in our 4-hour waiting times compared to the month of January that we've just been considering. So we've gone up to nearly 76% on 4 hours March to date, compared to dropping back to the high 60s both in January and sadly also in February. We are huddling daily with the senior teams, not just in ED, but across planned care as well, because this is a whole hospital approach and needs to be a whole hospital approach. I mean, I think our most key learnings from Watford were about coordinated leadership between medical, nursing and operations at every level, role modelled by execs, but undertaken at each level to service line and below. And the fact that it is a whole hospital process that needs to be taken as seriously by teams in imaging, teams in surgery, as it is at the front door. So I don't know if either of my exec colleagues want to add, but we're seeing really good improvements as a result of that work.
Teresa.
Yeah, I think, Lucy, you've done a really good job of sort of framing the position and the challenge. I think what we've got to do, getting back to the Better Basics campaign, is really centred around that early decision making, you know, whether that's at streaming, whether that's at first triage. So we're signposting patients to the right clinical team and not keeping them in an endless queue. And I think we're seeing some good progress there. There's a real opportunity for us to change how we run our emergency services for the better and improve our patient satisfaction. So whilst we're doing this, chasing the patient flow, what we want to do is some really smart measures around patient feedback, because that will really help and inform some of the richness around people who are perhaps regular attendants of our service and how we change that. So there's a whole systems approach there. I think the other wee bit that I would just add is that some of the systems that are nationally mandated, EMAC, etc., we are just on the threshold of implementing, because we want to do it through the lens of putting the patient genuinely first, getting the flow right, and making sure our clinicians and nurses are working together. You know, this is something we should be getting better at. We've got to make sure that every day and every shift and every hour is an opportunity. So this is plays to the strength of all our process redesign. So it should be exciting to watch your journey, hopefully, Chair.
Sounds great. Justin.
Sorry, you've got answers from all three of us, and I'm very much in agreement with what Lucy and Teresa have said. I just wanted to add in a bit that we've been doing some work with Eastern North Herts production system, looking at how we can leverage the information that gives us about our urgent emergency care performance. And one of the things we've looked at recently is what happens during industrial action. Everybody knows that flow improves during industrial action, and we've seen better performance figures. And the question is, what can we take from that for times when there is not industrial action? And the piece of work we've done has shown that there are some things that we can't replicate and wouldn't want to replicate outside of IA, but actually there is a whole load of other stuff that changes in IA that we can replicate outside. And I think that data that's coming out of that piece of work is really fascinating. And I think that will help us to work out how we take our service forward, learning from what we saw at Watford, learning from the national stuff that we're receiving at the moment, but also understanding our patients, our staff, and our infrastructure, so that we can get the very best for our patients out of what we've got.
Thank you, all three of you. I mean, that's really encouraging, and I think we look forward to seeing some further improvement in our performance in UEC as a result of all of those initiatives. I'm very conscious of time, but I would like to ask one other question, and I think this one is probably for Justin. I think all of us who read the papers or watch the news will be aware that there have been a number of recent high-profile cases involving outcomes from surgeons in some other trusts, where perhaps after a period of time it's been learnt that actually that there were questions raised about their performance and outcomes. It's not something that I hear about here, but I wondered whether, Justin, you could give us some assurance about how do we know, how would we know if we thought we had issues with some of our surgeons.
Anita, thank you very much for the question. It's a really important question. I think it's important for the board. I think it's also important for the patients that we serve. I think I'll divide the answers into two parts. The first bit is objective data, and we've got a number of sources of objective data that we can look at. So there are national studies of surgical outcomes. There's a particularly important one called NSIP. We also look really closely at mortality data. We present it in the IPR each time we come to board, and 4 times a year I also bring a paper on learning from deaths within the trust. Encompassed in that is our NELA data. So NELA is the National Audit of Laparotomies. And that's really, really important to see how we compare with other organisations on that. And we do well. And that's really important for our patients, because those are our very sickest patients undergoing surgery. We also look at our incident reports. We use a system called Enhance within the trust. And Teresa and I see every single enhance that is moderate harm or above on a daily basis. So we also have a real awareness of that. We then take significant incidents through our PCERT process, as you're aware, and we look very hard in detail to see what learning there is. And those are all objective ways of measuring outcomes from surgery, and they're all important. I think there's something else that's really important in this, and that's psychological safety. So I want to work in an organisation where if people have concerns or worries, they are happy to share them. And I think that's a responsibility that we all have to take on as leaders within the organisation, as the people who sit on the board of the organisation, to ensure that we create the psychological safety that means that people are happy to come and talk to us about things they're worried about. And for me, both those bits matter, both the objective data and the fact that we can create an environment where people can come up to us and talk about the stuff that they think is just not right. And I suppose the final bit of my answer is just an observation. As you know, I work clinically within the organisation, and what never fails to amaze me is how much more likely it is that people will come to talk to me about something they're worried about when I'm wearing scrubs than when I'm wearing a shirt or a jacket. And I don't know what that signals, but I just find it fascinating. And I'll stop. Hopefully that's a reasonable answer to the question.
Justin, thank you. That's a very comprehensive answer, and hopefully we'll give both board colleagues, staff, but also any members of the public some assurance that we are absolutely monitoring the situation. Thank you. If there are no other questions on the integrated performance report, thank you, Penny, for taking us through it. Excellent job. Really, really helpful. Thank you. Right. If we move on then, we are very short of time, but what we have are the committee reports. I know all of us will have done our homework, and therefore we can to a large extent take these as read. So I'm going to ask if the committee chairs could just highlight the one or two things that you think you would particularly want us to be brought to our attention, rather than perhaps give a full report, just in the interests of time. So I'm going to come first to David and Quality and Safety Committee. David, you appear to have frozen. Are you not? Oh, are you there?
Yes, I am. Sorry if it just keeps freezing at the critical moment. I'm going to say very little about my summary. I suppose one of interest might be Martha's Rule. I think it has been implemented successfully. I suppose I have a little quiet worry in the top of my head that actually demand will continue and it won't be steady, and we need to be prepared for that. I think we are, but we've been caught out on that sort of thing in the past. But otherwise, I think my report is straightforward. Thank you.
I'm on mute. I suppose the only other thing perhaps you could comment on, or perhaps whether Teresa or Justin want to get involved, is obviously one of the things you specifically did in the last couple of months was look at the NHS England call to action on antimicrobial resistance. Since that is something that was specifically mandated, actually I can see some hands, so maybe I'll go to the hands. Would you like to say something, David?
If we have time, I'd like to do a very quick introduction, and I can
please
make
do.
it quick.
No, please do it. I think that's important that we do that.
So I'm just going to do a bit of context and leave my more informed colleagues to give details. Why did we receive this letter? Well, only 10 or 20 years after the introduction of antibiotics, antimicrobial resistance became a clinical problem, and has been a clinical problem as long as I've been a clinician. Why did we get this letter? Well, things calmed down during COVID, so there were a few hidden advantages of COVID, but antimicrobial resistance has increased since COVID. And although as a country we're using less antibiotics, we're using more in acute trusts. And it's not an insignificant thing. There are 60,000 people a year who catch or are troubled by resistant infections, and it kills over 2,000. So, and my personal perspective, as far as I can see, is we're introducing very few new antibiotics when you consider how we're introducing wonderful new anti-cancer treatment. The new antibiotic list is really quite short. So I think it's always a problem. You can't forget it. Is on the government's national risk register. It could bite us one day. So it's one of those things we have to take seriously, and we need from time to time, we need a push. I'm going to keep quiet. That's my introduction. If there's details, my colleagues will help you.
Thank you, David. Teresa, Justin. Justin.
Do you want to go first, Teresa? Sorry.
Yeah, over to you, and then I'll come in.
Okay. So I suppose I want to offer a little bit of reassurance based on the regional and the national data in terms of the important thing here. It's that we start with broad spectrum antibiotics and we rapidly move to narrow or narrower spectrum antibiotics once we know what infection the patient has. And there is some data comparing us with all of the other trusts within the East of England. And we are the best performing at this, which is something that I'm really proud of. It shows that we've got really good microbiological support, and it also shows that the clinicians are responding very rapidly to that. So David's absolutely right. Antimicrobial stewardship is desperately important. It's something we as an organisation are doing pretty well at the moment.
Thank you, Justin. Teresa.
Yeah, just a massive shout out to our pharmacists who are really leading this work. They are absolutely just phenomenal at making sure that that conversion from IV to oral is well maintained. So just I think 2 quick points. I think David and Justin have really nailed it. It's obviously the stewardship is important, and so is the surveillance on the data. So whilst we are in a relatively good place, there's a real opportunity for us to work with the Cambridge Infectious Diseases Unit and their network, which we should do in our new world of the ICB, because that's where some of the real innovation and the global collaboration outside of the NHS is happening. So we've not quite got to that point yet, but we've certainly put our hat in the ring to say the more we can do locally to sustain and improve the plan, that's better. And you will see the national drives around 2027, that 5% reduction, working towards 2029 with a much bigger solution. There are no new antibiotics available. That's the biggest challenge that we have for anyone that reads a New Scientist at the moment. And not only that, the global challenge around agricultural issues with antimicrobials in the food chain is also another action. So just to say that finally, that work that we can do as a network could be quite exciting, Chair, and it's something we're exploring.
Yep, thank you. Karen, you wanted to come in.
Yeah, it was specifically to do with diagnostics and the blood culture sampling, and just wondering how our performance there was comparing with others, and wondering whether it had been impacted as we went over to the new contract.
Hang on, Karen, can I just pause you a second? Have we got any more on the antimicrobial resistance paper? But we'll come back to your question in just a second.
It is part of the antimicrobial.
Oh, is it? Apologies, sorry, I thought it was
yeah.
part of the other one. Please go then, sorry. Justin, did you want to come in on that?
Yeah, so the move to HSL hasn't made a difference to this. There is still an underlying problem about the volumes of blood that clinicians take when they're sending off blood cultures. And we know that whilst we're really good at switching smartly, we're not as good at this as we need to be. And it's still an area of focus for us as an organisation. And just for people who don't understand this area, the larger the blood sample you take, the more likely you are to find the bugs that you're looking for in the blood sample. And historically, clinicians have not always been brilliant at taking enough blood.
Okay, thank you. Thank you. Right, David, then finally to wrap this paper up, please.
As this was a request for board scrutiny, I just want to check up on follow-up, please, Anita, and what you want me to do. So QSC will follow this up. At the moment, it's simply going to go under BAU and will be one of the things we review. And I specifically asked if performance drops, but we have an earlier warning and an earlier paper, but I haven't done anything more now. Did you want us to do a formal 6-month review or what?
I think I thank you for the question. I was going to come to that. I think that what you are suggesting sounds very sensible to me. I think if we're monitoring the data and if it is flagged as soon as we see a deterioration in the data, I think doing it on a sort of an exception reporting, but periodically coming to QSC, I think is exactly right. So I'm very comfortable with that as an approach. So thank you. Then coming then to this paper, we are requested for an assurance level on it. It is proposed a partial. How do we feel about partial? That's the second level up. Are we comfortable with that? Should it be higher? Should it be lower?
I think it could be one up, but I'll leave it to my colleagues.
Okay, the proposal is reasonable. How would we feel about reasonable?
I would want to see the action plan and know that the actions were being actually implemented before being happy to put it up.
Okay, so that sounds like a sensible view. So if we go back to partial, are we comfortable with partial? Yep. Okay. Thank you very much. We will take partial, but hopefully, David, with that, once that action plan is there and once it's had that QSC scrutiny, it sounds like there's a lot in place here, and hopefully we can move it up, relatively quickly. Thank you very much. Okay, so we have officially 10 minutes to go through all the rest of the committee papers. So going back then. Can we take them as read, but can we please flag the key things? So Richard, finance, performance and planning.
Yeah, so I think Penny really summarized all the positive developments well, so I'm going to concentrate on some areas of concern. So whilst we heard, let's say, Lucy and Justin and Teresa talk about some of the learnings and the implementation in the UEC, I think when we look at the data in December and January, there was reason for concern, especially around adult type 1 UEC performance. And also because this was the first month that we saw a decline, not only from the previous months, but compared to 12 months ago. All year, we've been better than 12 months ago. So it's clearly an area of focus. On the RTT, we are still predicting that we're going to hit our targets, which is good. But the margin that we had in previous months has disappeared. So it's really down to very detailed management of RTT and the PTL. On the financial situation, we talked about it slightly. I think the concern is that our exit run rate is still deteriorating. So we will meet our financial targets for the year, but the underlying deficit has been growing month after month. So the transformation approach is really crucial in getting this improved. And I think the final thing, let's say, that's concerning me related to performance is that not a single month we have met our planned activity levels. And again, when you think about next year, those are the concerns for next year. I think underlying the thing that I'd like to emphasize is the need for addressing persistent underperformance. It's in the alert section of the board report. That is probably one of the things that's underpinning some of the performance that we see. Other than that, I think the rest is covered.
Thank you very much, Richard. Any questions or comments for Richard on that? No? Okay. Well, you'll also notice in the pack, oh, by the way, I should give apologies. I think we as board colleagues have got that summary in writing. They came too late to be uploaded to the website. So apologies to others who won't have access to the written paper, but I think Richard actually summarised it very well. However, one of the things we actually do have to do as a board is approve the terms of reference for the Finance, Planning and Performance Committee. And I think with the markups, there is a version in the pack. Can I ask for board confirmation of those terms of reference? Sorry, Adam, you wanted to come in.
Yeah, thank you. I'm happy to support. There is one caveat against each of the terms of reference. Whilst I wouldn't object to them being approved, we want to do a bit of work on officer membership, because a number of the committees have got a very heavy cast of execs and other senior people, and I think we just need to do a bit of work to streamline that. Otherwise, we run the risk of spending lots of time in meetings. But I wouldn't block the approval, because I think it is what it is now, and that's fine.
Yeah, and I think this is something that, it is a balancing act of making sure the right people know what's going on, but equally we don't want to take up too many executives' time with lots of committees. Yeah, let's have that conversation as an ongoing thing. Are we comfortable supporting the FPPC terms of reference as they currently stand? Yep. Some nods. Okay, thank you very much. Moving then on to People and Culture Committee. I apologise, we are going to overrun today. There's no way we can do everything in 5 minutes, but I'll try and get through as quickly as we can. Janet, paper is read. Anything you want to highlight?
Well, as Richard said, Penny's covered most of what was in this summary anyway, but I would just highlight a couple of areas for the board to know. One is that we continue to have challenges around BAME colleagues who are applying for promotions within the organisation, and really looking at that and working out how we might make improvement on that. So we'll be coming back to that. Also, from an assurance point of view, we are making better progress around policies that relate to deployment of staff, which clearly is part of our increased drive for productivity, is also helpful. And yeah, I think that's probably it. So I give you back the gift of time, Anita.
Thank you very much. Any questions or comments for Janet? No, great. We have the People and Culture Committee terms of reference in here. Again, similar to the previous one, the changes are marked up in red. Are we happy to approve? Subject to, as I say, Adam's general question that we possibly need to consider. But in terms of as they are we happy to approve those terms of reference? Yep. Thank you very much. Next one I have in is the HCP. Adam, anything you want to draw to our attention?
So attached to the paper is the performance report that we receive at HCP. The one area to just alert, you'll see referenced in that report, and this relates to cancer specifically under urology. And whilst we are still the third best performer across cancer targets in the country, it's not without constant daily management. And what we've seen in urology cancer referrals is an approximate 7% increase in activity. So it's just a highlight to the HCP understanding and why that volume has gone up. Is it better detection rates? Is it more active primary care involvement? So that's the only thing. Still performing, but it's an area of monitoring to go forward to maintain that performance.
Thank you, Adam. Any questions, comments for Adam? No, thank you. We'll take that one as read. Oh, sorry, Karen.
Apologies, it's really quick. It's just a request that in terms of the governance arrangements, when we get to the stage on the HCP, it would be useful just to have a discussion on them at the audit committee.
Thank you, Karen. That request is noted. Moving on then to ARC, Audit and Risk Committee. Again, taken as read, anything you want to draw to our attention?
The only thing I wanted to highlight is we have had a whole series of internal audit reports that have come through to audit committee. We will be considering those in detail in audit committees in March and in April. The one I wanted to particularly highlight was we've had 2 reports in terms of health and safety. And my request on those, because they link through to fire, water and electrical, and particularly on fire, we already have a detailed action plan in place across the trust, and we have an estates plan in relation to it. I have asked that when it comes back to audit committee, we've got linkage between both the internal audit report and that particular report as well, just to make sure we understand any health and safety risks that actually sit there within the round. That's really all I need to say. I think everything else is
thank you, Karen. I assume that Kevin will want to come in. So Kevin.
Very quickly, thank you very much for that, Karen. I agree in totality. We have gone back through RSM's reports and documents have been uploaded onto it. I expect the board will see a much improved position once it is updated. There is some in there, but just on regards to the fight, firstly, water and electric are bundled together, but the report on water is actually good. They're saying that the controls are operating effectively. So in essence, you could say electrical on that one. With regards to the fire risk assessments are now completed. They're all done. Evacuation procedures are being programmed, but it is extraordinarily difficult to tie that in with operational functionality. but we are dealing with that at the moment. On the electrical, they've asked for an electrical safety policy, which is done, and the testing to be done. There was a slight mix-up on that. What it actually means is fixed wire testing, which is the infrastructure of the hospital. That has been completed now, so that will be shown up. And the record keeping on the generator checks has been updated to so I am expecting a much better response coming back in line with what Karen said. I want to give people assurances that what is in here we've taken very seriously, and there's a lot of work and a huge amount of investment in the backlog maintenance through the team managed by Ali on that, especially with regards to the infrastructure, and new boards have been put in and out, and it's for the rest of this year as well and into the next year. We'll be rectifying the problems that we had. Thank you.
Great, thank you, Kevin. Good to hear that, and I'm sure Karen looks forward to seeing all of that in Audit and Risk Committee in due course. We have the Audit and Risk Committee terms of reference. Again, changes, which there aren't a vast number of them, but they are highlighted in red. Are we comfortable? Oh, Nina, you wanted to come in?
Just had a question for the quorum. It says any 2 members of the committee are required to be present, whereas in the other terms of reference, it tends to say 1 executive director and 2 non-executive directors, and I wasn't sure if we wanted to refine that bit or if that's fine.
It's the overarching makeup of an Audit and Risk Committee, which is different to the overarching makeup of others. But to be honest, Nina, I would always want either Martin there as the Director of Finance or his deputy there as well. But increasingly, we tend to call in people as we need them. So it's very much a committee that, for example, on health and safety, we'll have a representative from a state. So I just think it's important that we don't, otherwise at audit committee, we would need everybody basically, because we cover all audit and risk across the trust. So this is very much one where we only do it occasionally. There is a requirement for Adam to attend on a basis, and that's actually set out within the terms of reference.
Okay, thank you.
Thanks for the question, Nina. Thank you for the response, Karen. Adam wanted to come in.
Yeah, I'll just briefly add it, and it's the one committee that can only be a non-executive member, whereas the others all have executive members, but you can't be a member as exec, so hence the slight difference in nuance.
Yeah, it's also the only one that the chair isn't actually supposed to attend, which is the other slight. So that's why I rely on Karen very much to tell me what's going on. Yeah, it's the master committee, and therefore things are a little bit different for it. Right, are we happy to approve the Audit and Risk Committee terms of reference? Can I have some nods, thumbs? I'm getting thumbs. Thank you. Approved. Thank you very much. Moving on then, Charity Trust Committee. We don't have any papers because the meeting was only last week and we haven't been able to turn them round. Could you give us a very, very quick update, Nina, verbally, please?
Yeah, so just 2 things. One, we've got some movement on the Sunshine Terrace. So hopefully that will start to come through this year in actual building and seeing something visibly happen. And the second one refers back to a point that Adam made about some funding that we've got for the paediatric unit. So the charity is going to be working really closely with that team, and we have committed to doing a £2 million fundraise, which will be the largest that the charity has ever sort of embarked upon. So I think that the charity director will be reaching out to non-execs and execs to find out how we can all work together to make that really successful. But it's really exciting, so we're looking forward to supporting the paediatric team on that. And they presented on Friday, and yeah, it was, as always, incredibly passionate, and they really have got some amazing plans on what they're going to do around that.
Brilliant. Thank you, Nina. And yes, it really does sound very exciting. So yeah, great stuff. Thank you. We don't have any terms of reference for that one. Moving to digital. Now, can I just say I have actually scheduled an AOB issue in a private board. So we will be talking about this a little bit later. Mark and Richard are aware. But Richard, for this forum, anything you want to draw to our attention, please?
Yeah, essentially 3 points. First of all, We're transforming the committee from purely one EPR and outpatients transformation committee to more of a digital one, but we're still in the process. Clearly, the most important topic there is still one EPR. We've got a good internal plan for it, which would result in an implementation in November. That's very much predicated on the delivery of the software at the right time, in the right quality, and that is where our major concerns sit. We expect some major deliveries on the 27th of March and the 13th of April, and we need to make a decision mid-April if quality of that is sufficient to really stand by the implementation of November. So that's a really important thing. The second one is on digital outpatients. We're doing really well. I think the program is progressing well. We can see that in some of the performance. The biggest concern there is the recruiting for the contact center, and we take a lot of time internally to come to the actual recruitment. And if we don't recruit in time, that's going to definitely hurt performance, not just in the contact center, but much more broadly. So it's a real area that needs to be focused on. And then finally, maybe one of the additional topics that we briefly discussed, we've asked for a review on K2 in maternity, given quite a lot of feedback we got from the team over there to look into that into more detail.
Great, thank you very much, Richard. Any questions or comments? As I say, we will be having a further discussion in private board. I don't see any hands up. We have the digital committee terms of reference there. Again, this is a new set of terms of reference because obviously this is a new committee for us. Is everyone happy to approve that? Are there any questions or disagreements with anything in there? Karen.
It's just one high level point. It's just when you look at the terms of reference across each of the committees, they really are quite different in terms of the way they're laid out and some of the different aspects of it and the amount of detail they go into it. So although happy to approve, I just think maybe there is a piece of work for us to do when we go into next year, just to have a look at all of those terms of reference lined up.
Yes, exactly. I have to say I had the same thought myself, Karen, but obviously in Stuart's absence, it wasn't a conversation I could really pursue. But no, let's look at that, because I think having some level of consistency where that's appropriate would probably help. Kevin, you wanted to come in.
Just again, a small point. Is this a committee of the board or a time-limited committee of the board?
It is a full committee of the board, just like all the others. That was one of the changes, and that's why it's taken a little bit longer to get the terms of reference sorted. But no, this is an ongoing committee. So can I have agreement to those terms of reference, please? Approval? Yep, thank you very much. That is approved. Okay, I haven't been notified of any other business. I just wanted to make, just as a final comment, just wanted to draw attention for board colleagues that this is Titchafara's last full board meeting. Titch will be leaving us at the end of April. I don't know if he's still there. I hope he is, but I can see his camera is off. But it is his last full board meeting. You know, we very much enjoyed having your contributions and your different way of thinking, which is exactly what we've needed. So thank you for that, and we wish you well wherever you end up taking your NHS journey. We wish you well. Obviously, we will be seeing you in some other meetings before the end of April, but in terms of a board, this is the last one. Thank you very much.
Thank you, Chair.
Apologise. Thank you.